Okay, should be good. Can you see the link?
Yeah.
Perfect. So I will get rid of that. Look.
Cool, that's all live on YouTube.
I've made that quiet now, but it all looks like it's good to go. So now we're just waiting for Wendy, who will come, I'm sure. So, and if you've got the details, Sam, for the next 3.
Yeah, I think the emails have come through for those.
It was Greg O'Grady this Thursday. Hey, Wendy. Gosh, she looks glamorous in that picture, doesn't she?
Hello.
Are you glamorous or in scrubs? I mean, clearly scrubs are glamorous too.
So
Oh, yeah.
what I was going to do was wear exactly what was in my photo, because while I'm talking, I'm going to do this.
Nice.
Then I only have to concentrate on one thing.
Yeah, I hear you.
Yeah. Oh, no, I emailed you just in case you didn't know who I was. Just, yeah, there's this person I know.
Yeah, there's a woman I met in the corridor. Hopefully she's legit. I hear you.
Very good. Now, who's following the comments today?
I think that's me today.
Madison. Okay, cool. And so one question about the comments. So when people comment on YouTube, can everyone see them? Like, is it like a normal YouTube thing?
Yeah, so everyone will be able to see the comments.
Yeah. Okay.
And you're on live at the moment, Wendy.
Okay, great. Very good. Okay, so tell me when you want to my slides to go up.
Not for ages. It's just about putting up the link and then emailing it out and people picking it up. So that's why we go live at least 10 minutes before, because it allows people to pick it up, log on, and think about things like that.
Okay, very good. I've just maybe 5 minutes out. So the first slide they can look at before the talk starts.
Okay. So it will be
So
sorry, go on, Madison.
I'll send you the questions on the Zoom chat, but I can also say them out loud to you.
Yeah, interrupt away.
Okay.
Because yeah, so what's
because I can do both, and then if you see a question that you can answer while you're talking.
Yeah.
And then I can also, if you want to, like at the end, have questions.
Yeah, absolutely. From last week, I don't know whether there'll be questions. Yeah. But yeah, we'll just manage as it goes. I'm just wondering what I'll be able to see on my computer if I've got my presentation running and I'm sharing screen. Yeah, I'll have to work out how to get the comments so that I can see them.
You can open the chat as a chat box, and even if it's on your screen, it won't be visible to the people watching your screen.
Yeah, sure.
Yes, no, I can't wait to get back to live, students. It's all very well doing it online, but it's not the same.
Yeah.
And talking to a whole bunch of boxes just with names on, it's quite tricky. You know, no visual feedback, no bored looking people, no interested looking people, just comments sometimes.
I'm sure all interested.
Yeah, good comment, good comment. Surely you're looking forward to going back to live tutorials. Is it better online?
I just want to be in hospital.
Yeah.
Never think you'd say that, but yeah. I totally agree. It's just
The link's been sent out.
awesome. Thanks very much. So have you guys been given a plan about what will happen from the med school? Have you got an outline of when you're coming back or what you'll have to do or anything like that?
The last message we got was that would hopefully be back at level 2 to like potentially site and year dependent, or like site and run dependent, sorry, but apart from that, that's what we've heard.
That's good. Yes, I mean,
I'm on holiday this week.
You're on holiday? Oh, nice.
Yeah.
What are you doing with your holiday in your house where you've been for 2 months already?
I wrote a portfolio piece today.
Well, that's a great way to use your holiday.
Yeah, and yeah, that's about it.
Oh,
Yeah.
you can't even stop. Is that because whatever happens, the portfolio's got to be done and the year will get busier, so might as well check.
Yeah.
I can't bear it when I do that on my holiday. I think all my life will be better if I do some work on holiday and then I think, oh, stop. Come on, Wendy, I bet you do it too.
Yeah, I'm always working.
It's such a poor haul, but there we go. Sometimes it can't be that.
Would it be all right if I start sharing my screen?
Yeah, go for it.
Yeah.
You know I'm looking for the whys.
That's the aim.
I reckon I could win real chocolate.
Yeah, so medicine. So check to see whether anyone is brave enough to write in the comments.
Okay, no worries.
That's
I could write done in the comments.
Yeah. So,
Alison, how many people watched Tim's lecture last Thursday? Did you get a feel for that?
I can't remember exact numbers.
Do you think overall, as weeks go by, people watch more lectures or less lectures?
I think it varies. I think from memory there might have been, it was either 60 or 80 live, but I'll have a look now and see if there's a view count.
We've got one person that's said done.
hey, well done.
It wasn't me.
There've been 435 views.
Okay, so people who've clicked on it later. Or, you know, or watched it at the time. That's interesting, isn't it? Because a lot of people catch up later.
Yeah, I put out a feedback service as well, which has had some, I think we've got about 50 people have responded to it so far, which is always good. But yeah, certainly for the phase 2 like student-led tutorials that we've been running, I think 3/4 of people have been watching them like after the fact, not live.
Makes you think about what we ask you to do most of the time, which is turn up 8 till 4. But I'm expected to turn up for the normal working day, so it's kind of hard not to. You spotted all the whys, Sam.
I got distracted, but yeah, I think yeah, I've got them all.
Wendy's then going to tell us that there are actually 7. We're all Muppets. Right. Madison, have you done it?
I can only find 4.
Oh, it's a blind spot somewhere for 20%.
Oh, got it.
Maybe that's all you need to do, Wendy, is to spend an hour with visual puzzles. We'll give her another 3 minutes, see who's tuning in, and then we'll introduce you. Shall we kick off? Mainly because that will allow us to get started on time. So, hello, good evening, everybody. I hope you're all enjoying level 3. Fingers crossed for level 2, but 2 0 days has got to be good. Tonight's lecture is Untangling the Pain by Dr. Wendy Burgess, who, despite the fact that we've worked together for some time, has sent me a little bit of information. So just so you know, she's an obstetrician gynecologist, and now I can't open it, with a special interest in pelvic pain, and she works at North Shore, and I also know that she is an Auckland grad, so she's part of the team. So over to you, Wendy. Thanks very much.
Well, thank you, Laura, and to your team there for having me here to speak tonight. And thank you all for tuning in and listening. I appreciate that the allure of a gynecologist coming to talk to you about pain may not be the overwhelming thing you want to do tonight. And I know this is not as sexy as tropical medicine or brain surgery for epilepsy that we had last week, but I can assure you all that tonight's talk will be worthwhile. And I promise you all that there's not going to be too much O&G, just enough to explain why I came to love this world of pain, and hopefully by the end of the night you might too. So put the pens down and sit back, open up your mind as we go through these things. So firstly, congratulations and well done to those people who managed to find the whys, and those who have torn themselves away from the chase on Channel 1 to listen in. There's been some brave cookies down here that have put comments, so well done for sharp eyes finding the whys and bravery using the comment section. So I hope all of you will get brave enough to write things in the comment section. I love some interaction. If you've got something to say, if it's a question for me, even if it's just a question for the universe, if you've got a story you want to share, similar to one of the stories that I share tonight, put it in there. I love to hear people's pain stories. If you feel like complimenting me on my slide creation abilities, they are always welcome. But any comments will be great. So I'm going to start by getting you to think about pain. So think about the last time you were in pain. Or maybe think about the worst pain you've ever experienced. First of all, how did it make you feel? What are some of the words that you would use to describe how it felt? If you want to, you can feel free to drop those words in the comments. So words like sore, burning, twisting, unbearable, excruciating, sickening. These are all common words we use to describe pain. Now, this is something we do every day. We ask our patients to describe their pain. And the reason we have to ask them to describe it is because pain cannot be seen. It cannot be palpated, cannot be auscultated. We don't have a blood test to measure pain. We don't have an imaging sensitive enough to measure pain. So the first key message for tonight is that pain is an experience, not a sensation. Now, this may seem like a trivial differentiation to make, but it's really important. When we think about our senses, sensations like vision, hearing, touch, smell, taste, each of these, we have a specific test that we can do to measure them. But for pain, there is no test. Pain is always objective. The International Association for the Study of Pain defines pain as this: an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So yes, we can agree that pain is unpleasant. Yes, pain is an experience. Pain has both emotional component as well as a sensory component. And the words that we often use to describe it, describe them in terms such as damage, like tearing, piercing, stabbing. Now, the second key message about pain is that pain is essential to keep us alive. Pain's sole goal is to protect. Now, I know you haven't had much clinical experience, but what this man's leg is doing, that is not normal. He has 3 knees. The brain is constantly taking information from the environment and from within the body and making an assessment to the risk of danger. And if it assesses that the risk of danger is such that you should stop doing the action, it creates pain, like a cease and desist order to the body. So pain is universal and everyone has pain. To have pain is human, and if we didn't have pain, like the people with congenital insensitivity to pain syndrome, then you would die young. often in childhood, and often from unidentified injuries or disease. So pain is universal and pain is essential. The third key message for tonight is that pain is not a measure of tissue damage. There are many instances in life where in one context, say you were out fishing and a stray fishing hook pierced you through the leg, that would cause pain. But for others, cosmetic piercings or body alterations do not cause the debilitating pain that you would expect. It's all in context. Now, I was on my ED run back in 5th year, and I was sent out to an A&E clinic for the day. And this farmer comes in. Now, what I can say is, if you want good work stories, go and work in rural New Zealand. So anyway, this farmer had been up a tree, chopping off branches with his chainsaw. The chainsaw had hit a knot in the wood, bang, bounced back and got him straight in the abdomen. So this guy says, "Struth," because that's what farmers in the Waikato say, "Struth." And he jumped in his ute and he drove himself to Anglesea A&E. So what had happened here? His chainsaw had hit the knot, bounced back, hit his abdomen, torn a great big hole in his anterior abdominal wall. A message shot up the spinal cord into his thalamus. The brain receives the message, there's some danger in your anterior abdominal wall. The thalamus takes this message and sends it out to all the interested parties in the brain. Hey everyone, something's happened in the anterior abdominal wall. And in an instant, the brain makes an assessment. Although this danger is potentially life-threatening, it is not advantageous at this time for the body to have debilitating pain. At this time, it needs just enough pain so that he stops what he's doing and goes and gets help. So this is what happened. And some would call this stress-induced analgesia. The pain does what it needs to do for survival. Yes, before you ask, I made this graph. Thank you. And it's showing that when an injury is catastrophic, then there is often no pain because there's no longer any benefit, no longer any benefit to warn to prevent injury. The injury has occurred and can't be any worse. So when we think about the nervous system, input comes in from the nociceptor through the peripheral nerve into the spinal cord. It goes up the spinal cord and firstly to the thalamus. Now you think of the thalamus like a relay station. It takes that message and sends it to the necessary part of the brain. First of all, it sends it to the frontal lobe and it asks, should we be concerned about this? The frontal lobe says, have we been here before? Hold on, let me check with the posterior parietal cortex. Now the posterior parietal cortex, its job is to process touch, pain, pressure. Then it shoots the message across to the hippocampus because the hippocampus forms and stores all those memories of learning. I better check with the occipital lobe. So the occipital lobe asks, are there any visual inputs around that would suggest this is more or less dangerous? So the message that came from the spinal cord is now only one factor that is determining whether pain is going to be signaled or not and the severity of that pain. Our eyes, our vision, our hearing, our smell, personal memories, memories of loved ones' experiences, all those inputs combined to determine the final pain output. So my message 4 in regards to pain is that pain reflects the brain's assessment of danger. Now this works nicely for acute pain, and it's vital and it's essential to keep us alive. But what is not helpful is when this becomes chronic pain. So I'm going to get you all to squeeze your left earlobe. Now you're all at home and no one can see you, so just do it. Now squeeze it until it hurts, then stop. Now your brain is smart and it's going to give pain before actual tissue damage occurs. Otherwise, it'll be too late and it'll be pointless. Now, the interesting thing that studies have shown is if you had a friend squeeze your earlobe, exactly the same amount that you squeezed it, you would think it was more severe. More interesting still, if you had a stranger squeeze your earlobe, and I'm not sure why you would, but if you had a stranger squeeze your earlobe, the exact same amount that you did, you would feel it as more painful again. So this is your brain doing an assessment of danger and communicating it in the only way it knows how, by pain. So for a large number of people who experience chronic pain, their buffer, or the gap between the level that pain is signaled before actual danger, is too big. And we call this a sensitized nervous system. Their brain interprets things that are normal as being painful. Now we know everything in our body should heal within 3 to 6 months, but pain that remains beyond that time, we call chronic pain. We also know if a patient who has chronic pain for a significant number of years, even just seeing someone else bend over and picking up a box, their back will hurt. And we can see this on scans. The areas of their brain light up as if they were picking up the box. So they don't just think that it hurts, it actually neurophysiologically hurts. Now, chronic pain is not an uncommon problem in New Zealand. 1 in 5 people will experience chronic pain. And the cost to New Zealand is more than the cost of diabetes and dementia combined. Now, despite 60% of presentations to doctors being for pain, on average, only 4 hours of medical teaching is dedicated to the teaching of pain. There has been a lot of development and advancement in pain and pain management over the last decades. And we are really lucky at Auckland Medical School because we are one of the first medical schools in the world to teach the essential pain management program. And this is part of your curriculum. But 4 hours isn't a lot, so we can all benefit from more of a revision. Now, here's my story about how I got into pain. So I was coming up to finish my O&G specialist training. I was a year out. And so in order to give myself something extra to ensure that I got a job at the end of it, I needed to show that I could not only just do the things that every O&G specialist could do, but that I could do something else as well, something special, an extra feather in my cap. So you need to find a skill that can fill a gap in the particular department that you want to work in. So in O&G, we see a lot of pelvic pain. They often present to ED, inconsolable, distraught. Now, no one really knows what to do with them. No one enjoys working with pelvic pain. No one understands chronic pelvic pain. No one really has a good approach. So they use their acute pain approach, which is opiates, more opiates, surgery. So I saw this as a gap in our service, and I thought, hey, why don't I go away and I'll work out how to manage these patients. That way I can help prevent these women presenting to ED, help them from sitting on the wards for a week and then getting unnecessary laparoscopies just so that we can get them out again. And I saw this as a great benefit to our department or any department. So I went back to university. This was after my special exams, having sworn that I would never, ever sit another exam again. I went to the University of Otago, only because they're the only people who offer this paper. I did a distance learning program called the Certificate in Pain and Pain Management that's offered through the Musculoskeletal Department. On the course were pain nurses, some of them from Waitemata Pain Service, physiotherapists from all around the country, a rheumatologist, and a wide range of other professions. So this is a course that is 4 papers long. Most people would do it over 4 semesters or longer, but I only had a year to finish. So I finished it in 1 year, 2 papers a semester on top of full-time work. And I also had the opportunity to spend 1 day a week in the chronic pain service at my hospital. In there, I saw patients with chronic pain from all different reasons. So what I learned, along with every single nerve type, size, speed, characteristics, every layer of the dorsal horn and its special job to play, too many neurotransmitters to name. I learned to appreciate what pain is. I learned that if I explained to patients in a way that they could understand, and if I give them strategies or approaches that put them in control, then that is how you help people with chronic pain. Now I give talks on chronic pelvic pain. And when I give each of these talks, I explain how there's different organs that are all causing the pelvic pain. And I break it down into each of those systems and I explain how and why they're contributing to their pain. On average, women have 7 symptoms. I explain how the nervous system is over-reporting messages from their body. And I explain how the muscles of their pelvis are contracting to try to protect the area. I use lots of stories and analogies. And this is the one I use for pelvic floor spasm. So if you had a pain in your neck, then all the muscles around that area would go into spasm. Now the same thing is happening in your pelvis. But if you had a spasm in your neck, then you'd get a heat pack or you'd have a massage and you would do this and the spasm would ease. Well, you can't do this in your pelvis. So what we need to do are some special stretches. And now I take them to a fancy website that looks impressive. And I show them how a physiotherapist who specializes in pelvic pain has put together this group of stretches. And she's told us that if we do them every day, 30 seconds on each side, breathing mindfully while you do it, after 5 weeks, you will start to see a significant difference in your pain. And in case you need help with the technique and motivation, there is even a downloadable audio tape that goes with it. Now, just in this 1 minute of explanation, I've used every aspect of pain psychology and learning techniques. So part of this is a magic trick. And as in all magic tricks, if I explain it in detail, it might lose some of its magic. But the interesting thing is, it doesn't lose all the magic. like when we think of the placebo effect. So we all know the placebo effect works. If somebody thinks that they're having a treatment that is beneficial, then they will get more effect than if they didn't. Well, a recent paper was published, and it showed that even if the person knew that it was a placebo, they would still get some of the expected effect. So the brain is an amazing and fabulous thing, and we cannot fully comprehend it. Now, another explanation that I give is about a thing called visceral convergence. And this explains why women with dysmenorrhea or painful periods can often get associated painful bladder syndrome or irritable bowel syndrome. And I explain it like this. So in our pelvis, there's the bladder at the front, the uterus in the middle, and the bowel all around. Now, if one of those things are upset, then all the other organs get upset. And I explain that we can't just treat one of those organs if we expect to get improvements. So that is why it's so important that we treat the painful periods with hormones or suppression, that we treat the painful bladder with dietary changes or medicine, and we treat the irritable bowel all at the same time if we hope to get any benefit. Now I draw lots of diagrams, simple pen and paper diagrams. I walk step by step through our patient information handouts. I give them homework, listing out headings of their problems and then bullet points of what to do about each of those problems. I give them realistic timeframes, because in pelvic pain, as any chronic pain condition, it has taken a long time for your nervous system to adapt and change and become how it is. And so it's going to take some amount of time for it to change back again. So in pelvic pain, we talk about 5 weeks. So in general terms, it's going to take 5 weeks for any intervention to start showing any noticeable difference. I get them to keep pain diaries, or now there's apps that you can have on your phone. So I get them to keep symptom diaries and say, after 5 weeks, you can look back and you'll see that noticeable difference. So by doing this, what I'm really giving them is some acknowledgement that their pain is real, because pain is always real. I'm giving them reassurance that their pain that they're experiencing doesn't mean danger and it doesn't mean damage. I'm giving them an understanding of what pain is in simple messages, explaining that it's a simple message within the nerve. I'm giving them hope that things can get better. But most of all, I'm giving them empowerment to take back control, to control their recovery and control their lives. So my 5th key message about pain is that pain comes from the brain and it can be retrained. So those are the things that I use in gynecology, but every speciality has its own versions and its own chronic pain conditions. The most common specialities that deal with this are orthopedics, general practice, and rheumatology. But if we thought hard enough about it, I think in every speciality we could find a chronic pain condition. So a true, deep understanding and appreciation is important for all of us, whichever field we end up in. Now, another message which I think is important is that patients come to us for help. So we need to remember that help doesn't always need to be a prescription or an operation. Sometimes that help is just an explanation, a reassurance, and some hope. So I said it before, 60% of presentations to doctors are due to pain, and chronic pain affects 1 in 5 people. and chronic pain is a tremendous cost to the country. But despite all that, there are only 11 full-time pain medicine specialists in New Zealand. And I'm not one of them, I'm just special interest. So pain medicine is a branch of ANZCA, which is the College of Anaesthetists. It's a post-specialist training program, which means you have needed to complete a specialist training program before, and that training program needs to be related to pain in some way. Following that, you go into a 2-year full-time training program. You sit more exams, telling you you can never get away from exams. You do long cases. You have to work in a specially accredited unit around the country, of which Waitemata is one. But at the end, you get all these letters at the end of your name, so that is probably why they do it. Now I want to tell you one more story, and this is a story that we teach people in our acceptance commitment training as part of the chronic pain service. So when a person has pain, and we demonstrate that by picking up one of the chairs, the pain is like this chair. Now this chair is heavy, but it's manageable. And I can still get around when I have this pain, but it's a bit more of a struggle. I can do the things I need to do, but it just takes a little bit longer. But when this pain hangs around and I start to get worried and I get fear that there's something serious going on, something the doctors are missing, some danger within me, then it's as if I have another chair. And in this demonstration, we pick up a second chair. So now I'm carrying 2 chairs. And I thought life was tough before when I just had the pain, but now with 2 chairs, it's twice as hard. Twice as hard to get anywhere. There's some things that I used to do that I can't do now. Some things that I want to do, but I can't. And the longer this goes on, now I start getting depressed. So now I add the depressed chair. And in this demonstration, we pick up a 3rd chair. Now with a 3rd chair, I definitely can't go out and meet friends. I can't go to my children's sports activity. It takes all my effort and strength just to stay standing, holding these 3 chairs. Now we tell the story because the people in this room are often experiencing exactly that. They've had chronic pain for such a long time. No doctor has been able to fix it for them. They've had every test, every scan. They've tried every medication, but they still have chronic pain. Then we explain to them how if we manage the depression, if we do active things, if we try some mindfulness activities, if we try some medications, then at least we can lift off that 3rd chair. And then all of a sudden, even though we still have those 2 chairs, we're still able to go back and do some of the things that we couldn't do before. And then once we get some acceptance that we can have pain, and it may not mean that there's something going on inside, and it may not mean the message of danger, then we can put aside those fears and those worries, that anxiety. And now we're just left with that pain. And the pain might still be there, but it's not stopping us from getting on and doing the things that we can do. So this is another one of the stories that we use to demonstrate and help get the message of pain across. Now, so I'm going to stop there, or else I could go on all night giving these stories about pain. But what I want to do is encourage you to go from here and to go straight on to watch this YouTube clip. and it's called Understanding Pain in 5 Minutes. And it's put together by the Hunterville group in Australia, who are really the leading experts in the management of education in chronic pain. This is my favorite clip. I can watch it over and over again, and I use it in every single one of my talks. I would have played it tonight, but I was a little bit concerned about playing a YouTube within a YouTube, whether the kaleidoscope effect would pull down the whole platform. And I know we're all living at home and living off YouTube. But this clip is a beautifully composed clip. It's very easy to follow. It's great for patients and for health professionals, just to come back and remind us that pain is real, but pain is not danger, and we can come out the other side. Then I would recommend going from that clip straight into any clip by Lorimer Mosley. Now, Lorimer is a trained physiotherapist from Australia, but he is now one of the world's experts in pain science. He's the author of this book, Explaining Pain, and the founder of a group called Pain Revolution. Yeah, so the problems with chronic pain and the cost to society are not special to New Zealand, they're worldwide, and Australia has appreciated this and set up these special units. So I'm just grateful that your generation going through med school are the new generation, and you've got this new understanding of pain. You're getting good teaching through the EMP program. And so this is all second nature to you. But it's surprising, even to myself, who has a good appreciation of pain, is how quickly I revert back to my surgical mindset and want to fix it. And I think that is one of the characteristics as a doctor, is that we want to be able to be the person who fixes it. We want to give the medicine that fixes it. We want to do the surgery that takes away the problem. But that is not always the best thing or the thing that's needed. And I think, to me, I'm the happiest when my patients say, "Thanks for explaining that. I've been to so many doctors and I never understood it before." So I think that, to me, is more important than being able to do a certain operation in under an hour, or the other things surgeons compete on. So you were very lucky being of your generation. My generation is still stuck in the Descartes meets gate theory mentality. And so lastly, I just want you to think, if a patient asks you who is the better doctor, is it the doctor who can name 25 differential diagnoses for a raised LDH? Or is it a doctor who can take a pen and paper and explain what diabetes is and what it does in such a way that a 7-year-old child could understand? What do you think that patient would say? And who do you want to be? Or why not be both? Thank you.
Thank you so much, Wendy. That was awesome. I'm definitely of a generation where all we were taught about pain was the gate theory and the analgesic ladder, which in itself big pharma may have influenced. So we won't go into the politics of that. Madison, do we have any questions?
Yes, we do. How easily accessible are chronic pain services for patients?
Yeah, that's a great question. So there, in most of the hospital or the tertiary hospital around the countries, there are chronic pain services. Those services are chronically underfunded and under-resourced, meaning they can't see all the patients that they would want and hope to see. So their criteria for entry are often very strict. So the way the Wairemata Chronic Pain Service manages it is that they have a session, a 3-hour session where patients are invited to attend, and they get to meet each of the people within the chronic pain service, which is a multidisciplinary team approach, which has pain specialists who are often anaesthetists, physiotherapists, and psychologists who specialises in chronic pain. And they get to meet, and nurses with special interests in sleep management and medication adjustment. And they get to meet each of those people, and then they go away and they have to then fill in a 10-page questionnaire and return it, so to prove that they are invested in the program before they can attend. And these programs are often 6 weeks long, and a limited space on each of the programs. So so it is it's not easy to get into. Sometimes within the public service, people are assessed that they need one-on-one, either one-on-one with a psychologist or one-on-one with a pain specialist, and then they can do it that way. But we're definitely limited within the public system. There are groups in the private sector that can be accessed, and some of that can be accessed through ACC. ACC is now appreciating the cost of chronic pain, and so they've invested money in that to help people get the support that they need. So there are ways to do it in the private sector, but that is at a cost. All physiotherapy in the private is at a cost. So there are definitely limitations there.
I think those are all the questions.
Okay, well, that's awesome. Thanks very much, Wendy. That was definitely the best pain lecture I've been to. I'm really hoping that current medical students get a better education on pain. It'd be interesting if anyone has any feedback on that. So thanks very much. That was a really informative lecture for me, and I hope for all the students. Thursday, guys, is Greg O'Grady talking about novel devices for unmet clinical need. And so that will be at the usual time at 5 o'clock. So thanks very much, Wendy.